Hey folks, we're back. We're looking at Chapter 10, or the Embalming Analysis. The Embalming Analysis, one of the most important chapters in the book. How do we read the body so that we do the right things to it when we're preserving it? So, Embalming Analysis. Those analytical observations of the deceased human body by the embalmer before, during, and following the arterial embalming of the body. Incorporates relevant factors from the disciplines of anatomy, microbiology, pathology, chemistry, restorative art, and embalming. We have to read all the factors of the body, make an educated guess. Monitoring the body must continue until final disposition or release of custody to another funeral establishment. We're going to see that in a lot of other chapters going forward. So our embalming analysis continues, as it says, even after the injection of the body, to make sure that we continue to have the body in good condition until disposition. You need to document everything: analysis, monitoring, embalming techniques. So what did you see when you got the body? When it first came in, what did the body look like? That's why it says back in like chapter 1 or 2, you need to do an embalming report on every body that comes in. When and how often did you go in? Make sure you're kind of initialing and dating how often you check on the body and put it on the form, make it evidence. And then when you did embalm it, what were the techniques you used, what type of chemicals, etc. Your embalming, okay, or an embalming care report, same thing, should have space for all of this information. Historical textbooks described embalming treatment for a variety of problems, and treatment was limited to these items. No consideration was really given to anything else, time between death and prep, etc. So, Ray Slocum, the pre-embalming observation system, the typing, body typing system, okay, 1950 by Ray Slocum of the Dodge Company, based primarily on time between death and prep and degree of postmortem changes. Separate categories were developed for jaundice and infant cases, and there were a total of 6 categories. Each category then had its own recipe of embalming materials. By 1960, advances, i.e. drugs, big pharma, man, make the job more difficult. And now we're concerned with death, the effects of the meds, the postmortem changes, the delay between when the person died and when we got them. So obviously a typing system is not going to work very well. Condition caused by meds are one of our most common and primary concerns in the analysis. What did the medications do physiologically to the body that's now going to make our life miserable? Observed conditions are present-day embalming analysis. Covers observable conditions along with body information concerning death, and that provides everything we need to know. We do it before we start embalming, while we're embalming, and even after embalming is done. Consists of the 4 steps: observation, evaluation, proposed method of treatment, implementation of treatment, observation of results. The way I kind of paraphrase this is, what do I see? How do I fix that? Let me do it. Did it work? Okay? And then you repeat it. What do I see? How do I fix it? Let me do that. Did it work? If it did work, what do I see? Do I need to fix anything? Well, let me do that. And did it work? This always lets the body tell us what needs to be done. It is imperative that the embalmer, the funeral director, and the family all have strong contact. And this is even more important when you're running into compartmentalized business models where the embalmer and funeral director are not the same person. Embalmer needs to know date of disposition, preferred cosmetics. Funeral director needs to know about conditions of the body, so they buy the appropriate size container, etc. Paint a realistic expectation, especially a realistic expectation. And it is essential that satisfactory time be set for preservation and funeralization. Rush job should not be your standard. You want to be able to give yourself time to work and for the chemical to do its job. So general factors and treatments, this is a regurgitation, kind of looked that over, but pretty much you can eyeball this and know whether it's a general factor or not. Should have some idea on techniques, method of closures, etc., etc., etc. All the stuff we've talked about up until this point. Correct treatments are dictated by the conditions of the body, not by the cause of death. The cause of death is only one of the many factors we have to consider. 3 possible exceptions to that rule. Death by contagious disease, in which case the protocol set forth by your individual boards of health or the Centers for Disease Control will tell you what to do, and then you don't have an option because that's usually your legal obligation to the state. Death by aortic aneurysm. Immediate sectional embalming, no questions asked. If it's got a pop somewhere in the big vascular system, you are going to have to inject from 6 places at least. And death by renal failure, which usually means you're going to have to inject from some of the larger arteries, do drainage, so you can try to clear some of that yellow out, et cetera, et cetera, et cetera. But those are the only possible exceptions to this rule. In 99% of all cases, you're going to look at the conditions of the body. And do we not see in that third one, renal failure, jaundice, for instance, that is a condition of the body. So the guidelines, you must be able to see the body at all stages of prep. Okay, you must be able to see the body at all stages of prep. This brings into some discussions as to whether a person who is legally blind or completely blind may be able to effectively do the job. That would be difficult. That would be difficult, but not insurmountable. Embalm, of course, every body is, if it is infectious, sets a standard for embalming solution quality and disinfection hygiene, and prepare each body as if it's going to be a waiting game. That is also important, okay? Prepare every body as if it's going to be delayed. So a week or two down the pike, you might actually get something done. And this reinforces the standards you have for your solutions and also sets a standard for your embalming thoroughness, making sure distribution is actually distribution and not like, oh, I think it might have gotten there. I'll wait and see what happens. So extrinsic and intrinsic factors, as you can imagine, this is going to sound very close to stuff that we've seen in previous chapters, agonal, death and dying, for instance, etc. Okay? So just kind of look those over on your own time. And notice here an extrinsic factor is also the embalmer, okay? And a lot of that personal preference of the embalmer for a lot of the items we see. It's imperative that you can learn to do this. 4 factors of this analysis: conditions of the body, effects by disease, or what we think are disease, effects by the drugs or surgery, those are a bit more visible, and effects of the interval between death and embalming. That's usually body warm, body cold, body decomped or not. So be concerned with all conditions you can see, feel, and smell. You will generally not know cause of death anymore in a majority of states because variety of reasons, but most of them are going electronic, so you're not going to be able to see it like it used to be in the old days unless you still have paper forms that you can pick up at the time you pick up a body. So common variables, this is also something that we're not going to kind of beat to death. Areas you can find information if you can get a hold of it. So this brings into brings up an important point, that just because you do not have access to something, okay, does not mean it cannot be used. Professor Finn, if I don't have access, how can I use it? Because there is theory. We can get information from a death certificate if a death certificate exists. But to say that, oh no, we can't use it because we always get it after the fact, that is not always the case. You might have a family that is nowhere to be seen and there is a death certificate in the system, and you might be able to get that information prior to, okay? Prior to the embalming, because the family finally shows up. So conditions stated by the facility where death occurred. Listen to people and say, oh yeah, man, you won't believe it. This poor guy, he showed up, 2 nights ago looking fine, ended up catching something while he was here, and next thing we know, he started turning yellow, and he died. That would probably tell you which way you're going to steer this, okay? Information regarding disposition, especially if you're going to be shipping this out of country. You might want to make sure you know what the country you're shipping to wants to have in its bodies. And obviously specific family requests, shaving, scars, tumors, all sorts of good stuff. So general intrinsic body conditions. Age is important. With children or infants, we find vessels are much smaller. That means most of our tools are now not useful. Milder solutions, generally not high index, okay? Inject normal concentrations. So if I'm going to put in fluid, I'm going to use medium index fluid. Babies have a lot of water in them. So we don't need high index, we just need normal stuff and expect it to be diluted more. Needle injector may not be suitable because there's no bones. Use glues or sutures. And positioning typically varies depending on your area from that of an adult. Elderly, sclerosis may eliminate use of femorals. Absence of teeth complicates setting features. And suturing may be needed if jawbone is atrophied. Emaciation, solution strengths usually reduced You definitely want to go reaching for the high index stuff. You probably want to keep it around that 2%, okay, at best. And dehydration can create feature closure complications. If they're obese, femorals may be too deep for use, too much of a pain in the butt to get to, and then impractical for use anyways. You're going to have to inject enough solution to actually get the job done. Go back and think about that embalming math that we looked at a couple chapters ago. If we're using 3.5 bottles just for 160 pounds and no problem, what happens when we get a beefier that's like 500 pounds? You're going to have to do some serious math to find out what would my formaldehyde demand be. Here's a hint: more than 3 bottles, and go from there. Remember the old rule of thumb: 1 gallon for every 50 pounds. So if we're looking at a 500-pound person, we're looking at using close to like 10 gallons. That's a lot of fluid. Most people probably would not inject that. I would be very hesitant to do that myself. Restricted cervical injection to control solution entering the head is almost a given, and obviously positioning problems, especially if people buy the wrong casket. Athletic bodybuilder types, oh, these guys are going to pickle just great, let me tell you what. Okay, you hit them with the fluid and those muscles are going to suck that right up. Problem is, if they're in rigor, those muscles ain't going to move. You're going to be miserable. You might as well just wait for it to pass. Emaciation, loose skin, poor firming. Swelling can be anticipated if large volumes of mild solution is needed. So again, you cannot use a lot of strong stuff, but you have to make sure that that 2% is still being kept. Fatty fat does not firm as well as solid skin and tissue, so you're probably not going to get the firming that you like. We can observe and make speculations from what we see on the body in regards to disease processes. Always remember, jaundice is the problem more than the disease that caused it. Okay. Next paragraph of the book only served to show that multiple diseases cause similar effects. We treat symptoms, not the disease. Always ask, what condition exists? Jaundice exists. Not, well, let's see, was that hepatitis or was that something else? We don't particularly care about the hepatitis because of the fact that we have to assume they have hepatitis anyways. We treat the jaundice. Jaundice will always be the problem. The yellowing and the discoloration that results upon the reaction in the acidic environment, rather than the fact they have hepatitis. If conditions are identified and properly treated, the embalming procedure will succeed regardless of the disease that caused the condition. Almost anyone under treatment is going to get hit with 1,000 different meds, so we're just going to have to suck that up and move on. Medication use over time causes complications in bodies, may even cause different problems for different people. Always treat the symptom, not the drug. We don't care what drugs you were on. We only care about what those drugs cause and what we need to do to fix that for preservation purposes. So long-term complications of big pharma: jaundice, discolorations, edema, lack of tissue firmness as a result of waste byproduct buildup in the tissues, alopecia or loss of hair. That would be something we would have to deal with from a restoration standpoint, perhaps, or even brittle skin. Internal bleeding, renal failure. Remember, nitrogenous waste equals ammonia. Ammonia and formaldehyde are very happy together. Changes in walls of cells, making protein fixation difficult, chelating, a hard buildup of stuff on the outside of a cell, and swelling of facial tissue, especially when you use steroids. So chemotherapeutic agents does not refer to cancer treatment. It refers to any and all medications. All meds in some way are toxic to the body. May result in minor or no complications, and some can totally screw you up, royal, military, industrial grade style. Okay. Blood thinners, reduces post-mortem clotting. This is great because usually this improves distribution and by proxy diffusion. Increases hypostasis of blood and causes intense livor mortis. Zero cares given. That's intravascular. We can push that stuff out if we've done our job right. Okay? Expansion of the veins of the distal arm would be noted when arms are lower to the sides of the body. Cute. If I drop my arms down the side, the fluid's going to pull, causing expansion of stuff. It's kind of a no-brainer, okay? Scar over sternum, usually due to open heart surgery. That probably can tell you they're going to have sclerosis issues later on. This chart is awesome, okay? This chart is awesome. Look through this chart and know some of the results that are associated with their complication. And there are a lot of them, okay? Surgery may greatly influence your embalming decision, especially depending on the type of surgery, especially open heart. Good chance of leakage from vessels. Use dyes as tracers. Probably not going to want to use pre-injection. Use greater volume of solution to compensate for loss due to leakage. So if normally you'd put in 3.5, if they're leaking everywhere, you're going to have to probably put in more fluid to compensate for that. Thorough cavity treatment. Liberal amount used in surgery area, definitely. A hypodermic injection of cavity fluid in areas around the surgery area. And recent surgical incisions should be resutured prior to cavity treatment, because usually just kind of staple those together and away it goes. You're going to have a much more permanent and leak-resistant method than just surgical staple. Very important to reaspirate and re-inject in surgery cases for such reasons. Heart surgery and aortic repair, face and neck are going to be grossly distended and swollen with edema. Sectional embalming probably going to be required, and you should probably bet some money on your restricted cervical injection. Abdominal surgery. Bowel surgery can result in peritonitis, intense distension of the abdomen, bloodstream infection, septicemia, which means increased clotting factors. Okay, blood is going to be clumpy. Strong solution going to be required. You're going to have to deal with a lot of these problems by jacking up your percentage, if not your index. Changes can take precedence over conditions of the body due to age, meds, and time, or etc., due to the fact that time is going on. So time's taken away. Embalming is best accomplished as soon as possible following death. 3 common conditions you run into with time if there's nothing else messing with you. Blood coagulation, which makes distribution and diffusion a problem. Also runs into graying, okay, when the formaldehyde reacts with it. Rigor mortis, which makes injecting a bit problematic. Increases demand, formaldehyde demand. And decomposition, which is basically D, all of the above. Refrigeration will help delay this, okay? It slows the coagulation, delays the rigor, and slows decomp. But refrigeration can cause dehydration and a laundry list of other stuff, including the false signs of preservation due to hardened fats and reddish coloration to mimic dye distribution. Note these areas on your pre-embalming analysis. All too often in my labs, because I'm dictating the analysis to other people to write down on the forms, I forget because I don't have a reference handy. Autopsy bodies may be left out in a warm environment prior to autopsy before being returned to refrigeration. Yeah, they finish the autopsy, they kind of leave it on the table, and then they put it away a couple hours later. That's going to cause issues for you as the embalmer. So again, here are some time things that you need to look at and their significance as to why we care. Okay? So make sure you look through this. When you encounter a problem, adjust your approach. This isn't rocket science. This is embalming. Everything can follow the flow chart of what do I see? What do I do to fix that? Let me do that. Did it work? Then, what do I see? Boom, 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 boom. After every gallon of injection, reevaluate distribution, diffusion, and effects of the solution. Look for dyes, clearing of discolorations, firmness of tissues, whatever you need to, the signs and quote-unquote symptoms of arterial preservative distribution. Stimulation of flow of arterial solution. Ways you can kind of make this work. Massage along the arterial route. So you should be massaging in the direction the fluid is pushing to help kind of move it along. You could increase pressure, make it push a little bit harder. You could increase rate of flow, but increasing rate of flow can lead to swelling. Okay. Lower, raise, manipulate the area. Let gravity work, move it around. And close off drainage to build intravascular pressure, or IVP. Areas that do not receive solution must be sectionally embalmed. Now, what usually happens here when you ask a question regarding this is people immediately assume, okay, that, oh, I don't have to inject that area sectionally. It didn't receive solution. I'm not going to worry about it. I'm just going to go right to my hypos. Do not do that, okay? You try to sectionally inject it first, and then you move on to the hypodermic injection and cavity compresses. Strengthen your solution by adding higher index fluid during an injection. Remember, you can make it stronger, just never make it milder. Continue to inject solution as long as no visible distension, to ensure additives are injected. If you're leaking a lot, but you're getting no swelling and you're actually getting distribution, keep injecting until you feel that things are sufficiently done. The most important portion of solution being injected is that which stays in the body. Duh! Right? If it's not in the body, it ain't doing its job and no one cares. We need to know how much is in there doing the job. So you're going to have to eyeball what's coming out. Intermittent draining will retain more embalming solution than concurrent draining. No-brainer. Turning it on and off while you're injecting is going to hold more in there because it keeps the pressure pushing. Up to 55% can be lost as drainage. The most common number is 50%, okay? 50% of all solution is contained in drainage. If you see dryness of skin or dehydration, you might want to add in a humectant. You might want to put some massage cream on it as well. If you see a lack of color, add some color. Add the dye. Purge. Let purge continue unless the purge is arterial solution. If the purge is arterial solution in drainage, inject larger quantities to ensure adequate preservation. If purge is solution only, you have a major rupture of the vasculature somewhere, so you should stop what you're doing and inject. See, if purge is arterial solution and drainage, then we're getting something working because blood is coming out too. But if we're only getting arterial solution coming out of an orifice, we have a serious problem. We need to stop and we need to address things on a part-by-part basis. So factors that can affect tissue firmness: renal failure, buildup of nitrogenous waste, ammonia byproducts, etc. Emaciation, the muscles themselves are in crap condition as a result of lack of nutrition. Edema, there's a lot of water, and that's diluting my chemical. Hence, I need to probably inject more or get some of the water out. Wasting degenerative diseases, kind of all the above. And poor low index or slow firming chemical. If you're using a slow firming chemical, do not expect it to firm quick. If you doubt firmness, increase index by preparing a new solution, add some high index to an existing solution, or add more concentrated solution, same index, into what you already have. You're just upping it a notch. Drainage site. If you're draining from the femoral, notice discoloration building in the neck and head, open the jugular, relieve the pressure. Same goes for other body areas. If you notice the arm is, building up, open up the arm. Find the axillary or brachial nerve or basilar vein, axial or basilar vein, open those up and let it drain. So we check bodies after embalming on a daily basis. Some of you overachievers try to tell me, oh, it's best to check them hourly. If your funeral home has enough time in your day where you can check every body by the hour, you probably need to, up your marketing game some. When receiving a body from another funeral home, check every damn thing. Strip them down to their birthday suit and look it over. Because if you say the body was in good condition, oh, but I didn't check underneath, you said the body was in good condition, okay? And then consider your treatments: re-injection, supplemental preservative treatments, cavity reaspiration injection, new methods of closure. If the body still exhibits a lack of distribution after you're done, you may have to go in sectionally first. If that doesn't work, then you break in the hypodermic as well as cavity packs, etc. So your indicators, kind of a no-brainer. No, you don't see any dyes? It probably did not inject very well. Maybe you see dyes, but there's little or no firming. Presence of intravascular discolorations. Clearly, if you have livor mortis after you're done injecting a body in a place, in a portion of the body, it did not inject because the stuff is still in the arteries. Sectionally embalm it and get the stuff out. Cavity treatment. Immediately after or delayed depends on body conditions or time body should be ready for viewing and services. There's going to be a whole chapter dedicated to cavity treatment coming up. You may have to let humectant chemical work to try to fill out emaciated bodies, so you don't want to go poking holes in your vasculature, so you're going to delay the cavity treatment. You may wish to also delay to allow chemical to disinfect a possibly contagious body. So you might want to inject cavity fluid and aspirate several hours later if you can. Ensure mouth is dry. You don't want stuff building up in there and causing odors and problems. Remove dirty or wet cotton, replace with dry stuff. Tissues must be dry for adhesives to work. If eyelids are soft, Use cotton with a drop of cavity fluid before gluing shut. If air is in the mouth after gluing, lips can be opened or aspirated via trocar. Purge, simple. Take out the dirty stuff, repack it with clean stuff, okay? Aspirate nose, throat, and clean the mouth. You do not want to leave purge material in the oral orifices. Anal purge, this is the fun one, okay? Remember, you signed up for this. Force out as much fecal matter as possible. Push down on the abdomen with your fist. Try to get as much turd out as possible. Pack the orifice with cotton soaked in cavity fluid, phenol, or any skin lesion treatment, so gels basically. Okay, when we say packing the orifice, that doesn't just mean put a little bit in the anus. You probably want to get a lot more. You want to try to, pack some cotton and stuff into the rectum if you can. Use an AV plug, whatever it is. There are so many different ways I have seen this as a question. Pack the colon, pack the rectum, pack the anal orifice, pack the anus. It all means the same exact thing. Utilize a purse string suture if necessary. So yes, you can sew an anus shut. I have never had to do that. Never. Okay? Never had to do that. But if you have extreme atrophy where they've been, putting them on an ostomy, for instance, and they've been lying in bed non-responsive for nearly a decade, chances are you're going to have some issues packing the anal orifice, which means you're going to be using definitely diaper, coveralls, pants, everything you possibly can to prevent a bad situation. Grooming, nails, clean and trimmed. I mean, no-brainer. When you are, prior to your embalming, you should probably go in and start cleaning out nails. I know a lot of embalmers, even myself, I'll go in there and clean during, but you have to make sure that while you are embalming, you are paying attention for swelling. So if you are going to, quote-unquote, try to multitask, that can lead to some problems later. So be very careful when you are multitasking while you are injecting. Hair, ensure hair is clean and dry. Hygiene, make sure you body on its side, scrub down its back. Don't just get the top area, okay? Ulcers, treat them with compresses. Replace compress with clean ones prior to dressing, okay? You want them nice and disinfected. Use plastic garments and tape to hold a compress in position. Saran wrap, plastic wrap works very well for this as well. Leakage. Well, seal trocar buttons with superglue if you need to, or make the hole a little bit bigger and use a trocar button in a non-visible area. I can also hypodermically inject cauterant, which is not in the book. You get the phenol or carbolic acid, go in, kind of channel and leave some of that around. You might be able to burn whatever is leaking shut. Trachs and colostomies. Well, purse string suture after packing with cotton and cautery chemical. Tracheotomy can be filled with some sealing powder, then cover with glue and cotton after closing. Sutures need to be tight and not seeping. If you need to resuture it, try to resuture it tighter. This can be difficult in areas of the body where the skin is very tight, like the legs, the lower legs especially. So you have a great little chart here which tells you a little bit of everything. So make sure you look this over. This is important because you need to be able to play the game. You can't just say, well, this is what it says in this paragraph. So these charts are an excellent way for you to kind of figure out what I can do in the situation, and will overwhelmingly be very, very useful to you when it gets to your exit course requirements and your professional examinations. Remember, check the body daily. If we're checking something hourly, it's probably because they're on display. So you should be checking the body after and during, visitation periods to make sure nothing bad is happening. So it tells you right here, treatments for certain conditions. This is a wealth of information. I would make a note card for every single one of these were I you. Okay? So dehydration. What are the causes of it? What are the results of it? You should know this. Purge. What causes it? 99.999% of all questions out there. I'm not going to say 100 because there's going to be some random damn question that doesn't call for it. But if you have purge, you need to fix it now. You need to fix it yesterday. You should have fixed it prior so you didn't have the problem now, but that, is sometimes unavoidable. But you definitely need to fix it, okay? Reaspirate. Open and dry the mouth. Get everything clean again. If there's odor, may be caused by gases accumulating, decomposition, or debris somewhere on the body. It's not in your book. That's a practical. If you did not clean the body appropriately, if you missed a little bit of blood in the hair, for instance, you would be surprised how bad that will stink later. Reaspirate, re-inject if it's coming from cavities. May have to re-embalm if it's a result of decomposition because of a lack of distribution. You can temporarily mask it with powders and garments, but this doesn't solve it. You need to address the issue so that it does not continue. Leakage. Source can be edema or incision not sutured properly. Soiled garments must be dried and cleaned or replaced altogether, which is why you should be using plastic garments along with resuturing and sealing powder to prevent garments from getting trashed to begin with. Softening of visible tissues. Well, discoloration of tissue, skin slips, or water-filled pustules or blebs are indicators that things are starting to go south on you. Usually it's because you didn't do the embalming right. So get back in there, re-inject arterially, re-inject sectionally if you need to, go in with the hypodermic needle, surface pack, whatever it takes to fix it. Tissue gas, man, okay, you better hope it's not the real stuff because that's going to be a problem for you. But if it's just gas in the tissues, crepitation and swelling are evident. If it's true tissue gas, you will know it because your nose will never forget it. And yeah, you're screwed. You're going to have to go in and re-embalm with the appropriate type of chemicals, and you are going to have to hit it like a ton of bricks because this is nasty stuff. And true tissue gas, you need to be careful because it is contagious, and if it gets into you, it will kill you indiscriminately. When circulation is anticipated to be a problem, go for the common carotid and jugular as your injection site. Okay? If you have to use massive amounts or high index of chemicals for a body, always get the head isolated from it. You don't want all of that getting in there because it's going to cause problems with dehydration. Whenever swelling is evident or anticipated, go immediately for restricted cervical injection. Again, rule of thumb, if it's going to be an issue, isolate the head. When injecting a strong solution, or after injecting a strong solution, never inject a weaker. Always inject the weak solution first, then kick it up a notch. This will cause a dehydrating effect as the milder solution will pull the stronger solution out of the tissues if you inject it second. After you clear intravascular discolorations, use an average or mild solution for best results. Medium index, 2% hypotonic, medium index. You can increase it later if you have to up your game. You can also safely use intermittent or alternate drainage at this times. Okay, so realistically, if you've flushed your intravascular issues, you know, your livor mortis is gone, you might as well go normal. Chances are that's exactly what they're looking for. Normal case, normal index. Folks, thank you for your attention, and we will see you next time.